Genetic testing is one additional component that, again, is personalized for a patient, and we can get answers to questions we never had before, and we can treat patients before they even develop a breast cancer, which is amazing.
Welcome to Your Body, the healthcast that takes a deep dive inside your health. No matter what kind of health issue you're experiencing, whether it's the common cold, a bad case of eczema, heart disease, or breast cancer, it affects you in every way, physically, mentally, emotionally, and internally. This podcast seeks to understand what is going on with our bodies from the inside out, from our heads to our toes, and everything else in between. We're going to look at health issues from every angle and hopefully get a better understanding of what's going on with our bodies and how we can better take care of them. I'm your host, Stephanie Landon, editorial manager at RadNet, a leader in outpatient imaging services and an advocate of patient empowerment for over 35 years.
I just didn't want my kids to have the stress, you know?
Yeah.
But it's a fact of life. And look, I'm still here, and my mom and my sister didn't have the benefit.
What if you had the ability to look into the future and see if you were at risk for breast cancer, or prostate cancer, or some other life-threatening disease? Would you do it? What if finding out meant that you could make changes in your current lifestyle that could reduce your risk for becoming sick? Or if finding out meant that your family members, your siblings, your parents, your children could understand their own risks and mitigate their healthcare choices accordingly? Would you do it then? What if I told you that it actually is possible to do just this? We're talking about genetic testing. This is a science that has evolved tremendously over the last several years and has the potential to affect so many lives. According to the National Cancer Institute, almost 80% of women who inherit the BRCA genetic mutation, also known as BRCA, will develop breast cancer by the time they are 70 years old. That's 80%. The BRCA mutations also carry significant risks for other cancers, including ovarian, fallopian tube cancer, and primary peritoneal cancer. And women who do have breast cancer, who carry the BRCA1 gene, have a worse prognosis. Men with BRCA mutations are also at increased risk of prostate cancer and breast cancer. In addition to the BRCA mutations, there are currently over 50 inherited genetic mutations that have been identified to increase cancer risk and for which genetic testing is now available.
We know about my grandmother rode for the Pony Express, and my grandmother played basketball when she was, but no one tells the stories about cancer, the cancer stories in the family, but I guess we have to.
This is Jennifer Trent. She and I have been friends for almost 20 years. We met when our kids were babies, when our biggest problems were temper tantrums and swimming lessons. Cancer wasn't really a thing we worried too much about until Jennifer's sister was diagnosed with stage 4 ovarian cancer.
My sister, she was having some issues with not being able to, frankly, poop. She wasn't able to poop, and they gave her, the colon prep.
Yeah.
And she drank a whole bottle of it and still wasn't able. There was a serious blockage. She threw up, went into emergency. They did an emergency surgery, and she was full of cancer. Stage 4, started in the ovaries, and they said it looked like someone took a wet toothbrush and flicked it, and there was just cancer all over her insides.
And that was the first.
That was the first time we had even thought someone in our family could have cancer. And so that was kind of the opening, where we all were like, what's going on? This is crazy. No one and I remember sitting here at my house talking to my husband and a girlfriend saying, nobody has cancer in my family. This is crazy.
Right.
Then we started thinking, oh, but wait, my cousin Joni got breast cancer when she was 25. And then we were like, oh, I wonder if that's related. And then we started doing research and talking to family members. And then my grandfather's sister died of cancer of the gut. you know, and that was Arkansas, and that was like the early 1900s or whatever. And so, you know, they didn't know what it was then.
Right.
So then we did some research and found, oh, this is probably a thing. So I remember talking to my sister back then, and she just didn't want to get genetically tested. She said, it doesn't matter. I have it. You know, I know I have ovarian, so I don't need to get tested. So that was her philosophy. My mom talked to her doctors in Arkansas, and they said, they didn't offer the genetic test, my mom.
Right.
She said, well, can you check out my ovaries? And they said, your ovaries are all shriveled up. We can have them removed, but they're all shriveled up. They're like raisins, so there's no need. That's what they said. So then a few years later, my mom gets ovarian cancer.
And this was after your sister had passed.
Yes, this was after my sister passed away. And then my mom got a double whammy of breast cancer and ovarian cancer.
On the shriveled up ovaries.
On her shriveled up ovaries. And so when she got that diagnosis, she was like, you need to get the genetic test.
Yeah.
And I didn't want to.
I remember that because I was working at RadNet, so I had some knowledge, and I remember nagging you about it.
Yeah, we had another friend that nagged too, and I just thought, I don't want to know. You know, I don't want to know because I felt like it was very extreme because I knew what I'd have to do.
Right.
And so I just didn't want to know. But then, you know, my mom got it, and I could see she was very worried. So I thought, all right, well, this is ridiculous. I need to just go get tested.
It did take you a while, though, I remember.
And then I got tested, and I was BRCA1 positive.
Before I let Jennifer continue, I want to dig in a little bit into genetic testing and high-risk assessment. Like, what does it mean to be high risk? How do you know if you qualify for a genetic test? What happens if you do have a gene mutation? And it seems like I should also share at this point that I had breast cancer about 10 years ago, and I've done some genetic testing myself. I just recently retested, and my results were negative, but I'm still considered high risk. So what does that mean?
My name's Sarah Campion. I am a certified genetic counselor by training, and at Ambry Genetics, I work as a genomic science liaison.
I decided to go right to the source to see if I could get some answers. What exactly is the role of a genetic counselor?
So genetic counselors are trained both in the science of genetics, but also from a psychosocial standpoint to provide counseling to patients who are considering genetic testing or maybe have had genetic testing, and really help them navigate on the front end. You know, what are the benefits of testing? What are the limitations? What is this going to tell you? Answer all of those questions and, you know, discuss downstream implications for those patients. And then more so on the back end, which is now it's kind of an interesting time in the world of genetic counseling. We're shifting a little bit to more of this kind of back end support for patients and providers. So for those patients who do have especially a positive genetic mutation, meaning that they are at an increased risk for certain diseases such as cancer, we help those patients understand what that mutation means for them in regards to their risk, their management options, sometimes their treatment options if they have an active diagnosis of cancer, and then talk to them about the implications for their family members as well.
Yeah, that's interesting. Because I know I did the genetic test through Ambry, and I know one of the things it said was that if you had a positive mutation, that they recommend that your immediate family, children, siblings also do the genetic testing.
Yep, exactly. Yep, because they would all have those first degree relatives that you just listed, parents, siblings, and children, all have a 50-50 chance to also inherit that genetic mutation, especially in that hereditary cancer space. Right.
So what is the process? I mean, I did the test, but I'd love to hear you explain the process for testing and getting your results and understanding your results.
Sure. So there's a couple of ways that patients can go about getting the genetic test. Right now, we very heavily rely on physicians to identify these patients. And the way that you find out what patients are appropriate candidates for genetic testing. And again, I'm focusing specifically in the hereditary cancer space.
Right.
The way that you do that assessment is it's extremely benign. You take a family history. So you ask about those family members, those first degrees, those second degree relatives, which would be grandparents, aunts, and uncles, as well as third degree relatives as well. So even great aunts, great uncles, great grandparents, cousins, really getting a thorough family history and seeing, are there features of hereditary cancers or anything concerning? Because as you know, Stephanie, that cancer unfortunately is just super common. And just because you have, some cancer in the family doesn't necessarily mean that you're at a high risk to carry a genetic mutation. There have to be certain features, at least today, we say that there need to be certain features in the family that would make an individual an appropriate candidate for genetic testing. So some of these features are, certain types of cancers at a young age, certain amounts of cancers in a family or in an individual. So if we're seeing, 3 diagnoses of the same types of cancers or related types of cancers on the same side of the family, we would be concerned. Certain pathologies of certain types of cancers. So there's actually quite a few different criteria that can qualify a patient for genetic testing. So again, right now we really rely on those healthcare providers to identify those patients and either order the genetic testing themselves or refer them out to see a genetic counselor. It's challenging for all healthcare providers to equally assess all patients with a thorough family history. That takes time, it takes knowledge, and providers are caring for so many other aspects of healthcare.
Right.
It can be a challenge for healthcare providers to even identify those patients, let alone get them out to see a genetic counselor. There may not be a genetic counselor available. That patient may not follow through. We see quite a high dropout of patients actually seeing that genetic counselor once there's a referral. So, because some of these limitations that we're seeing and just unfortunately not enough patients getting identified just in general, we're looking at some of these alternative methods to identify these patients, such as utilizing artificial intelligence and chatbot technology, where patients can, sit down at their own leisure, talk to their own family members as needed, and, capture all this information in an electronic setting and automate this process of identifying patients based on that family history that's entered. So utilizing tools like this is really on the forefront right now. And it's really exciting to see what we're doing, by leveraging technology in the genetic space.
Yeah.
But I know I didn't quite answer your question.
No,
fully,
that's okay.
But
what I find interesting about that is that, so much of the, the qualifications for genetic testing has changed. I know that so I was diagnosed with breast cancer 10 years ago. And at that time, I, just a year prior, I did not qualify. I wasn't considered high risk. And a lot of those same factors I still have today. And those same factors today qualify me as high risk. So I think it's interesting that a lot has changed over the course of 10 years. A lot of cancer on my father's side wasn't considered a high risk factor 10 years ago, but today it is. Yeah.
Yeah. And you bring up such an excellent point that, as our knowledge evolves, we're going to keep identifying more and more factors that can identify patients as being appropriate candidates for genetic testing. And we follow the National Comprehensive Cancer Network guidelines. They put forth a set of guidelines that let you know the types of cancers, the type of features we need to look at in the family history that would identify those patients. And those update as our knowledge and our research and the amount of data available is updated over time. But those guidelines change multiple times throughout the year. So we find even in some instances, an example of a recent update, just the NCCN breast, ovarian, and pancreatic guidelines just updated less than a month ago now, that now any woman who has breast cancer that is triple negative, so all negative hormone receptors, those patients, regardless of their age of diagnosis, they all qualify for genetic testing now. Whereas a month and a half ago, if you were 61 and you had triple negative breast cancer and no other family history, you would not qualify. So we even see, discrepancies like that on a shorter term basis. So especially across the last 5, 10, 15 years, things have changed very drastically, as you point out.
Yeah. So what would be your recommendation as far as retesting goes for people?
That's such a good question, and I always struggle with this because it really depends on the type of testing that you had done prior. My general rule of thumb is that if it's been more than 5 years, more than likely you're going to be a good candidate to retest with genetic testing. And that's because a number of different reasons. Our technology just in general has changed quite dramatically. Just over the last couple of years, we've had an update in the technology that's used in genetic testing where we utilize different parts of our genetic material. So just over the last couple of years, there's been a little bit of an update that's now identifying more mutations for patients. But prior to that, there was this really big expansion in genetic testing where we kind of shifted the technology that we used for genetic testing. We went to a platform called Next Generation Sequencing that allowed us to do genetic testing on a much broader scale. So we could analyze more genes all at the same time. So we ran them simultaneously. We can analyze tens to hundreds to thousands of genes at a time. And it was done in a much more cost-effective and shorter turnaround time frame there. So we shifted from this kind of single gene workflow of doing genetic testing to doing what we now call multi-gene panel tests. So anyone who has tested prior to those multi-gene panel tests even being available, they would certainly be good candidates to undergo genetic testing because we have more genes that we now know about and can test for.
Right.
But there are a number of different factors. So it's always a good idea to talk with your doctor or a genetic counselor if there's one available to discuss that with.
Right. Interesting. So I'm going to discuss my personal results. I actually tested negative, which I was surprised about because there is a lot of cancer in my family. But so if I'm considered high risk, but I do not have a gene mutation, is there a difference? Like, am I just like, okay, good, I'm done. I can just go on, or is there a difference?
Yeah, so you bring up such a good point, and I think this is something that's really important just for general knowledge for the general population to really understand about genetic testing. Because when you undergo genetic testing, it's because we're concerned that, there's more cancer in the family or suspicious features of cancer in the family that we suspect that it's due to a genetic mutation being passed on from generation to generation. Now, only 5 to 10% of people who have these features are actually going to have a genetic mutation that's being passed on from generation to generation. So we see a lot of individuals such as yourself where we have these features in the family, but the genetic testing is negative. And why can that be? Well, that can happen for a number of different reasons. The first scenario would be you are negative because there's actually no genetic mutation in the family at all. However, it's still important for your family members to keep in mind that there's still cancer in the family, and there are other reasons why cancer can happen within a family. When we're seeing more cancer in a family than we would expect to, and there's no genetic mutation that's really causative of that cancer, we believe that those family members may still be at a slightly increased risk for those types of cancers in the family because of shared genetic factors that we're still learning how to interpret. There's a lot of, these really tiny little genetic markers that we all carry that can maybe increase our risk for certain types of cancers by a fraction of a percent. So just one of those little factors on its own doesn't mean much, but we have so many of these tiny little factors. So we're still learning how to interpret these small little markers within our DNA. So that's one reason, but also families tend to share environmental and lifestyle factors with one another. So the family just as a whole may have some type of exposure, some type of shared exposure that's slightly elevating their risk. So if the genetic testing in the family is negative, but there's still quite a bit of breast cancer in the family, it's a good idea for those females in the family to talk to their doctor about the family history of breast cancer because they may still be considered higher risk compared to the general population. And therefore qualify for some advanced screening options that they otherwise would not have had access to. So, that's one reason we can see a negative result, that we believe that there's these other factors that are playing a role in the overall risk in the family.
Right.
Another reason can be that, maybe there is a mutation in the family and we just haven't discovered the gene yet, or we don't have the right technology quite yet to capture that mutation. So that's where situations of retesting in the future, as our technology and knowledge continues to evolve, may still be appropriate for individuals and their families.
Right.
And then the very last cause for a negative result that I can think of here would just be that, just because one family member in the family tests negative doesn't rule out that there's not a mutation in the family. And I've seen this on a handful of occasions where, maybe there was two sisters that came in for genetic testing because they were both diagnosed with breast cancer at a fairly young age. One sister tests positive and one sister tests negative for that for a family mutation. Well, breast cancer and a lot of these other cancer types that can be hereditary are also just very common in the general population. So it's really important to keep in mind that just because one family member undergoes testing and they're negative, if there's still a strong family history, it still might make sense for other family members to undergo genetic testing to really make sure that there's not truly a mutation in the family, that this one family member just did not inherit and developed that cancer or acquired that cancer just on their own.
Right. That's interesting. And that definitely goes to the retesting that we talked about earlier. So overall, what do you say that the benefits are to just testing in general for people?
So I believe, and I'm certainly a biased individual working and living in this space, but I believe that there are just so many benefits to genetic testing. I think especially nowadays, we're all just a lot more proactive with our health. With our health, we have a lot more access to knowledge and our own medical records and things like that. I think just in general, the general population has a higher interest in genetics, which I find very exciting. It's a little bit less taboo than what you would see in the past. So just having access to this type of information and the level that our knowledge has gotten to just in general in the genetic space is able to capture this information in a way that makes sense for patients. I think historically, a lot of patients looked at genetic testing and thought it was this big, scary, expensive thing that very few people had access to. But really, we're finding that more people than we ever really thought are good candidates to undergo genetic testing for hereditary cancer and identify if they carry certain genetic risks. Now, if we do find a genetic mutation, this individual now knows what their cancer risks are with much more detail than they ever would have known before. They can know, what type of cancer risks are elevated, and in a lot of situations to how high that risk might be, and kind of what ages are we at the most risk for these types of cancers. And from there, we've developed guidelines for the vast majority of these genes to tell, and these are guidelines that have been put forth based on evidence and research. These guidelines that tell us how to best manage these risks, whether it's in regards to high-risk screening so that we can capture a cancer at an earlier age, preventative options such as chemo prevention, which is medications that we can take to reduce those risks, surgical options to reduce those risks. Sometimes people even take it into their own hands and make some lifestyle changes to help reduce some of their cancer risks.
Right.
Additionally, just really changing the landscape of what we see in a patient's family history. To me, I think that kind of carries the biggest benefit for families. Coming from clinic and seeing thousands of patients and discussing their family histories, it was always so sad to see patients talk about maybe their own generation and then their parents' generation and then their grandparents' generation. And it's all of these horrible cancers that were happening and people who were passing away at young ages and really suffering through these cancer treatments. Well, once we can identify a mutation in the family, we can now pinpoint who in the family is at risk and now can benefit from high-risk screening and preventative options, and who in the family is not at risk and just has the general population risk for cancer. And we can really shift those future generations and really see a difference in the quality of life for those family members and longevity of life for those family members moving forward.
People want to learn more about themselves, whether it's due to cancer risk or just to their history, and it's become more and more available in the market. It's mainstream, which has helped the cause for genetic testing.
Right.
But we have to be careful on what's truly a medical grade test that has real clear proven results and data and research to support the efficacy of a genetic test, ensure that we're giving you true information that's based on evidence rather than a non-medical grade test that might give you some facts, but might, the variability of on accuracy versus just points of discussion is the big difference.
Ambry Genetics is a company made up of scientists, genetic counselors, and physicians. They have been dedicated to the science of identifying genetic information for over 20 years. Through their CARE program, they are partnering with physicians and facilities, such as RadNet's BreastLink, to identify high-risk patients and provide testing.
My name is Ryan Friedman. I am one of the area directors for our enterprise business. My sole focus as a leader within this team, and my team's sole focus is to work with health systems and providers across the country on implementing a high-risk assessment solution to help identify, educate, test, and medically manage when there's any disposition for hereditary cancer risk.
After my conversation with Sarah, I wanted to find out a little more about the big picture of genetic testing. Like Sarah, Ryan Friedman also works for Ambry.
So I think the science has evolved greatly. I think when we look at the governing bodies that oversee hereditary cancer risk and genetic testing, medical management, the NCCN and others, I think we're finding that genes or genetic disposition really truly play a key part in understanding a patient's risk. And I think over time, as we've identified more and more genes that lead to hereditary cancer, it's helped us educate and manage patients differently. This is critical, but I think there's also an understanding, to your point, that hereditary cancer is not just about BRCA1 and 2 or breast cancer. It applies to 8 different types of hereditary cancers. And part of our goal is to ensure that providers understand that when we talk about high-risk assessment, it's not just breast cancer, but it's colon cancer, prostate cancer, melanoma, et cetera, all that apply, and that there's 36 genes that are managed by the NCCN that have recommended medical management based on their hereditary disposition, meaning their personal family history. And I think as time has evolved, it's allowed us to understand how we identify and assess patients so to determine if they do meet criteria for being high risk per those guidelines that have been established. And every year, every month, every day, that's evolving simply because as the science evolves, we learn more and more to help us manage this differently. And ultimately with our solution, that's what we do. We do the heavy lifting for health systems and providers and automate it, taking away all the guesswork involved to ensure that when a patient like yourself comes in, they don't need to know every guideline for all types of hereditary cancer or what genes are applicable or not, but they can address the patient with an automated solution that's robust and proven to capture these patients early and often to move from a reactive approach to a more proactive, preventative approach.
Right, right. So where do you see genetic testing going as it's evolving so quickly?
Yeah, I mean, excuse me, I think what we're finding is that genetic testing has become a key indicator in medical management to move from a one-size-shoe-fits-all approach to a personalized medical understanding of a patient's genetic profile and risk association to provide personalized and precision medical management. So, long short, I think as we understand more about genes and hereditary cancer, it allows us to be more proactive and preventative with care, with the ultimate goal and understanding if we can't cure cancer, wouldn't the next best thing be to prevent it? And I think that's where you're seeing the business go, is getting ahead of this early and often with proactive preventive, medical management.
Right, right. That's very cool. So what about, like someone like me, what would you say the recommendation would be for retesting, as things
It's a great question. I think the first and more important question is, how do we get better at this? Because right now, specifically to women, 80% of women that are high risk aren't notified until they're symptomatic and diagnosed. That's a huge miss on everybody's part, patients, providers, health systems. So I think we need to move away from our current processes and procedures and move to a better manner of identifying and screening these patients. And I think that's why you're seeing all these medical organizations or societies, clearly coming out and saying that we need to be more proactive with preventative screening. And when we get there, it's going to allow us to capture these patients more frequently to prevent these types of diagnoses. I think that all starts with approaching this with a more standardized, comprehensive manner. And I truly believe that the more we move away from a manual process and the expectation that providers or health systems need to own this responsibility and introducing technology to help support that, we're going to get closer and closer to a standard of care that allows us to treat all patients the same way with the standardized, comprehensive approach to actively assess these patients routinely and provide clear, precise medical management based on what we find.
Mm-hmm. Right. So explain to me how that's implemented.
Yeah, so we have a software that is very straightforward. It's something that can integrate with, health systems EMRs across the country. And that's one key component of it. We always strive to introduce a solution that's both operationally and clinically streamlined to make sure it's something that a health system or clinic can implement. Mm-hmm. But it's also bigger than that. It's understanding what the goals are for providers and clinics, today versus where we want to go, and putting together a plan that not only screens and identifies patients, educates them, provides genetic counseling services if needed, provides genetic testing services if needed, and most importantly, has the ability to provide information to providers and patients if they're considered high risk. What are the action items that need to take place from a medical manager perspective to ensure that they have the proper proactive preventative screening and prophylactic surgery or other types of diagnostics to ensure that we get ahead of any type of diagnosis or symptoms.
Right. So I'm curious, what is it that differentiates Ambry's testing from just a test kit you could buy at CVS?
Yeah, so Ambry Genetics provides a true medical grade testing portfolio. So there's many options we provide within our CLIA-approved super lab, focused on all genes that are recognized within medical management guidelines, allowing us to excel at translating science research into clinically actionable test results based upon a deep understanding of the human genome and biology behind genetic disease. Ultimately, we care about what happens to real people, their families, and their people they love, and remain dedicated to providing them and their clinicians with deeper knowledge and fresh insights. So together they can make informed, potentially life-altering health decisions.
Whether you're going to get genetic testing or you're diagnosed with breast cancer or maybe a pre-malignant disease, stay informed, ask all the questions you have. It doesn't matter if you think they're stupid or you're embarrassed. Ask everything. It's okay to read things on the internet, but take it with a grain of salt and just try to make sure you have all the information you need to make the decision that you feel comfortable with and that you're comfortable with your doctor.
At this point, I thought we should get the perspective of a physician. So I'm speaking with Dr. Valentina Bonev. She's a high-risk breast cancer specialist and breast surgical oncologist for BreastLink. She provides high-risk assessment for patients and management to those either identified as high risk or for those who test positive for a variant. First, I want to talk about your role at BreastLink as a high-risk breast cancer specialist and what this entails.
Right. So basically, patients who are deemed high risk by either their primary care provider or another referring provider are referred to me to be really evaluated. Are they truly high risk? And then what needs to be done based on their risk factors? And then, of course, I see patients who underwent genetic testing and are found to have a pathogenic mutation in one of the breast cancer causing genes, such as the BRCA1 or 2 or BRCA, which is the most well-known breast cancer gene out there. And so typically what I do is it's a normal history and physical, going into their personal history, their family history, and then my ears perk up if they're telling me, oh yeah, there's someone in my family who had pancreatic cancer, and then my mom had breast cancer, or if there's a male in the family that had breast cancer, when you start seeing a pattern, that's when you get alerted that, okay, it seems like this patient is high risk. There's also more objective ways of doing it, which is using a risk calculator, and probably the most known one is the Tyrer-Cuzick risk calculator, and that gives you an actual percentage of where your risk lies compared to the general population. And so in that scenario, you have a tangible number, and it guides you, well, is this patient truly high risk, or are they average risk? If they're high risk, then we talk about what strategies we need to do for this patient, and includes increased imaging surveillance, possible prophylactic surgery, possible chemo prevention. And so they will also get referrals to a medical oncologist, usually a gynecology oncology physician as well, and then they see their primary to review everything that we talked about.
Right. So is there a difference between someone being high risk and testing positive for a gene mutation?
Right. So you can be high risk for breast cancer without having a gene mutation. So some of these patients, they may never end up getting tested because they don't know about it or they don't want to. And some of these patients may get tested and they may have no mutation found. Now, that's great to have a negative result. However, a negative result does not mean that you will never develop any type of cancer in the future. So if based on your personal and family history, we do find out you're high risk, then we modify our treatment as such, because we want to prevent the patient in terms of like prophylactic management, in terms of getting a cancer in the future.
Right, right. So in what ways do these kinds of results affect your management of patients?
So for patients, first thing we talk about is increased imaging surveillance. So if you're just an average risk woman for breast cancer, we recommend starting with an annual mammogram at 40 years old. Now, if you're deemed high risk or you are found to have one of the breast cancer associated gene mutations, we talk about supplementing it with annual MRI as well. So that's the increased imaging surveillance program that we offer here. Another thing to talk about is prophylactic surgery. So in that case, it would be prophylactic bilateral mastectomy. And then there's, of course, option if the patient wants reconstruction by a plastic surgeon or not. Some patients may choose to go down that route because they don't want to get annual mammogram and MRI. They don't want that high risk of getting a breast cancer, so they would rather just proceed with straight to surgery. But it's prophylactic, so they don't have a actual diagnosis of breast cancer, but you're doing that surgery in the hopes that they essentially bring their risk of breast cancer to very low levels. And then there's also endocrine therapy, or it's also known as chemo prevention, which is a pill that a patient takes to lower their risk of breast cancer. And that's something the medical oncologist talks about. And there are risk and benefits, of course, to any medication you take. So the patient has a lot of options. And then, of course, they're having breast exam by me, the breast surgeon, every 6 months, or at least once a year. And then they're seeing their primary care doctor, who also is doing a breast exam. So at least someone is doing a formal breast exam with them every 6 months.
Right. And are there levels of genetic mutations, like someone who's has a higher risk than someone else? Is there a difference? Who would opt for prophylactic surgery versus someone who would just opt for, regular surveillance?
Right. So if someone had genetic testing and they tested positive for the BRCA mutation, either one or two, their risk of breast cancer is going to be upwards of 60%. And it could be around, depending on their age, 70, 80%, especially if they have a very strong family history of breast cancer. So multiple generations of members affected with that. a lot of patients with that diagnosis will want to proceed with prophylactic surgery. Now, there's other mutations which are known to be associated with increased breast cancer risk, and their risk, it varies. So there's mutations like CDH1, which is also associated with hereditary gastric cancer, and that's a whole other cancer you have to talk about and meet with a surgical oncologist about. And those patients often will actually get a prophylactic gastrectomy, which is a big deal, and they get it usually around like 18, 20 years old. So that's a big deal too, to think about. So patients in that case have to, think about, well, should I remove my breast, my stomach? It's a lot to go through. But there are other mutations like CHEK2 mutation, and that risk, for example, varies 15 to 40% for an absolute breast cancer risk. So there is a lot of variability. So patients may see that and say, well, hopefully I'm in the lower risk group, so let's just proceed with imaging surveillance, and we do. And then some patients, after a while, they're like, you know what, I'm tired of just getting this imaging. I'm tired of what could happen. I just want to go ahead and do surgery.
Right. Yeah. I mean, living with that kind of thing hanging over you can be very anxiety inducing, I'm sure. So, so what is your recommendation for genetic testing, for proceeding with genetic testing?
So for a patient that I see, like I said, I evaluate them, and it's based on their personal history, family history, if they meet criteria. So we follow NCCN, or the National Comprehensive Cancer Network guidelines for genetic testing, then I will offer it to them. So things to trigger genetic testing is if they have a known blood relative who has a pathogenic mutation, such as in the BRCA gene, so then we will want to test the patient. If they have a family history of multiple first or second degree relatives with breast, ovarian, pancreatic, prostate cancer, that triggers genetic testing. In the rare scenario, they have a male relative who has breast cancer, that is definitely going to trigger genetic testing for that patient. And then another group to consider genetic testing is going to be the Ashkenazi Jewish population. So to give you a comparison, the general population has about a 1 in 400 chance of having a mutated BRCA gene, versus Ashkenazi Jewish population has a 1 in 40 chance of having a mutated BRCA gene. So this is something I talk to patients about and offer it to them. And then I have other patients who have absolutely no risk factors, super healthy, nothing going on with them, and they say, you know what, I just want to get genetic testing. I just want to get the results. I want to know what could possibly be out there. And I talk to them about risk and benefits of testing. And sometimes insurance doesn't cover it if they're not meeting guidelines. And some patients say, I'm willing to pay out of pocket, and they want to get it. And I say, okay, we can go ahead and get it if you want to. It'll probably be negative, but if you really want to, as long as you understand, sure, we can go ahead and do it.
Right. So I know that at BreastLink there's now a program for testing, or at the BreastLink in Orange. So what is that about?
Right. So we have the CARE program, which is at both the BreastLink in Orange and Newport Beach locations. So patients who come in who are getting their annual mammogram, for example, one that their family medicine doctor ordered, we're going to have them fill out a questionnaire, which is based on their personal and family history. And that goes into a portal that sees if they're meeting, based on their answers, the guidelines that I had mentioned from NCCN. And if they qualify for it, which means they meet guidelines, which means insurance should likely be covering it, then we say, okay, you are, deemed someone who has potentially a risk of breast cancer based on your history, and we're offering genetic testing. And so they can oftentimes they're getting the saliva swab, which you did as well.
Right.
But we also offer, like if I'm seeing them in the clinic, we can do a blood draw too. And if they do the swab, they can do it at home. For example, they get the kit mailed to them, they do the quick swab, very easy, and then they mail it, and then the results come a couple of weeks later. And of course, if they end up testing positive for a mutation, we have them see the genetic counselor. They review the results with their referring provider. And then if it's in a breast cancer associated gene mutation, then we would have them see the breast surgeon like myself, and we can talk about, okay, now what do we do? What does this mean? What potentially can happen in the future? And how can we combat you from having a breast cancer?
Right. And this is every woman who comes in for a mammogram has this questionnaire.
Right. As long as they fill out the questionnaire,
yeah.
Yes, they have the opportunity to participate in this.
Right. I mean, do you see any drawbacks from participating or, having a genetic test if you're high risk?
As long as patients know that, like I mentioned before, a negative result does not mean you will not develop cancer. I think for some patients, getting genetic testing gives them some peace of mind, though, if they end up testing negative and have a few family members with cancer. Although sometimes results can also lead to anxiety because you can get like an indeterminate result, and that can be worrisome and confusing.
Right.
And it can also, the good thing is it can help you make informed decisions about your health. So some patients, we get surprised, meaning they meet guidelines, but still not super suspicious, and because they have like maybe a distant relative or a couple relatives with breast cancer, and then they end up having a unexpected mutation, and then you're like, oh my gosh, wow, we need to act on this.
Right.
So I mean, it's great in those cases, and so we can treat the patients right away.
One of the other things I think is interesting, and we've sort of covered different topics in other episodes of this podcast, is that it seems like medicine in general is kind of moving toward this more personalized, approach to healthcare. And would you say that this is sort of along those lines, another component of like personalized medicine?
Yeah, definitely. Management of breast cancer has become more and more personalized, which is amazing for patients because they have so many options, which sometimes can actually be confusing because there's so many options for them, but it's great because it's not black and white. It's not cookie cutter, like everyone who walks in the door with breast cancer has to be treated one way. No, there's different ways of treating it, and then they'll all have the same outcomes, which is amazing because patients have choices and they can decide what works best for them. And then genetic testing is one additional component that, again, is personalized for a patient, and we can get answers to questions we never had before, and we can treat patients before they even develop a breast cancer, which is amazing.
Yeah, it really is. And I imagine that as testing continues to evolve,
it will improve, definitely.
Yeah.
We'll get more information, and we'll find out about probably genes we didn't even know were associated with breast cancer or ovarian cancer. And it's really going to be fine-tuned. And I think we're going to have a lot more information in the next 5 to 10 years, and it's going to be great.
Let's get back to Jennifer. After learning all of this about genetic testing, when you hear Jennifer call herself a previvor, I hope it will resonate with you as much as it has with me. What a great term, previvor.
What I found when I got my genetic test results, there really wasn't anybody who could talk to me about it. Yeah. Like there weren't, the counselor was like, yeah, well, you're positive, you know?
Yeah.
But that was about it.
Right.
So I was feeling my way with my gynecologist, who I love. She delivered both of my kids, and I felt really close to her. And we just decided to go ahead and have the surgery. So it was a double mastectomy and a full, like, just take everything, you know, the ovaries, fallopian tubes, uterus, just everything. Because I saw my sister die a very, very painful death. And my mother was going through chemo. And, you know, we just thought it would be the safest to get.
Right.
I did not get rid of my lymph nodes, but everything else. We did. Yeah. And the recovery was tough. Yeah. But, you know, I am now a pre-viver.
So right.
Here I am.
So what about, I mean, do you talk with anybody now about, you know, what kind of screenings or any kind of care that you take now?
Well, when I had my surgeries, I was very careful about the doctors that I chose, like everybody would be. There was one guy, he was very experienced. He was over at the, should I say where?
Yeah, you can.
I don't remember his name, but he was like a very big shot over at the Samuel Ocean Center at Cedars. Okay. And
I remember when you were there.
I came in and talked to him about having the ovarian, I guess the hysterectomy and the oophorectomy and everything. And I said, what about hormone replacement? And he goes, you don't need hormones. Yeah. He's like, you don't need hormones. And I'm like, well, actually, I'm 35. Yeah. I kind of do. Right. You know, and then my gynecologist was like, oh my God, you're going to be dry skin, vaginal dryness. You're going to have, you're going to get old. You're going to be forgetful. Your hair's going to, you know, she just like, gave me this huge list of things.
Because you were going to be in menopause at 35.
Yeah, it was surgical menopause. Boom. Yeah. And I'm like, well, what other choice do I have? Right. You know? So she gave me like a bunch of hormones to just try. Okay. So it's just, there wasn't anybody who could really help me.
I mean, it definitely was different.
Yeah. I had to feel my way. Yeah. And I don't know if things are different now. Yeah. I go to see those same doctors.
You do.
Oh, I didn't want that old guy who told me I didn't need hormones. Yeah. I was like, bye-bye. And I took his younger associate, who I thought was a little more sensitive to the issue. Yeah. And as it turned out, his wife works at the breast center, the Brandman Breast Center over there. And she did my mastectomy and he did my hysterectomy. Oh. So it was like a family thing. And I'm like, yeah, I wanted you guys because I know you'll talk about me at breakfast. Right. And so I'm very comfortable with your communication. And then, so I go to see them.
Yeah. What do they do when you go in now regularly?
So the breast center, they just do a regular breast exam, even though it's, implants. Yeah. They still check everything. They do blood tests for the CA125 protein. Yeah. And then I get a pelvic exam. Yeah. And then he just feels around and sees if there's anything, to worry about.
Right. So that's good though.
Yeah. They do a urine test too, I think. Yeah.
Okay. And what about, I mean, you have 2 boys, but still they can be carriers.
Yes. So what we found out through all the research is that this gene started with my grandfather. Oh. And so because my grandmother lived until she was 90 something. Right. And never had an issue. My grandfather, like I mentioned, his sister died of gut cancer. My grandparents had 6 kids. And of those kids, 3 were boys and 3 were girls. And my mom was positive. Her sister was negative, but her other sister passed away. Her other 2 sisters passed away. I guess it was 2 boys and 4 girls. And then my cousins, about 60% of them are positive. Oh, so they've all had mastectomies and they've all had oophorectomies. And it's a crazy family tradition. Yeah. It's really, pernicious in the family.
Right. And this is all on your mother's side.
Yeah, it's all on my mother's side. So I talked to my boys, and in fact, I just talked to them. They're 21 and 18 now. And I didn't want to put it on them when they were younger, because I didn't want them to stress out and stuff. Yeah. But now that they're adults, I thought we should have this conversation. So we did it this summer when we were on our family vacation in Hawaii.
Well, that's fun.
Yes, it was a good time. And I said, I want you to be aware that this is a thing and you should probably get tested. And they have taken it in, but neither one of them have come to me and said they wanted to get tested yet. Yeah. But,
I mean, there is some research that does say that this mutation can be prostate cancer in men. Mm-hmm.
Yeah, that's what I mentioned to them. And I'm not sure if there's a connection to skin cancer.
There might be.
I thought there was.
There is. Well, I know that when I just did the questionnaire, that is one of the cancers that they ask about.
Yeah.
It's so different. Like there's so much more like than when you did it and when I did it. Like now they asked about skin cancers, lymphoma, leukemia, which is both on my father's side, in addition to and prostate. So they've really added so much more that are either linked together or that they're looking for.
Oh, interesting.
Mm-hmm. So
interesting.
Yeah.
Did you say your dad was positive, or did he have?
I don't know that he tested. I think I'm the only one that's tested.
Oh, interesting.
Yeah, because I had breast cancer under the age of 50.
Mm-hmm.
So, but he had lymphoma. His brother had leukemia. His mother died of breast cancer, and her sister died of breast cancer.
Well, there you go. Yeah.
But I still tested negative.
You were negative.
I was negative.
I just didn't want my kids to have the stress, Yeah. But it's a fact of life. And look, I'm still here, and my mom and my sister didn't have the benefit, Yeah.
See, that's I think what's so amazing about this evolution of testing is that you can get ahead of things.
Yeah.
Because, oh my gosh, right?
Yeah. And just being so unaware of the family history, you know, which is interesting. I mean, we know about my grandmother rode for the Pony Express, and my grandmother played basketball when she was, but no one tells the stories about cancer, the cancer stories in the family, but I guess we have to.
I think previous generations were very quiet about health issues, which is unfortunate.
Yeah.
I think now we have to be more
Yeah.
Open about that stuff because it's important. So you were lucky that you were able to do the testing and get ahead of it, but how does that make you feel?
I don't have survivor guilt.
Right.
I don't. Maybe that's bad.
No.
But I just wish that I wish that my sister had gotten the genetic test, so my mom would have known to get it.
Yeah.
Yeah. But now, we can't look back. You have to look forward.
Of course.
And just, I have to be really adamant that these boys know that they could be a carrier.
Yeah.
And they could pass it along if they have daughters.
Yeah.
Even if they have sons, they can pass it along.
I mean, and they could be they should know just for their own healthcare management. Yeah. I think as they get older.
Yeah.
So
luckily, because I've had these surgeries, I'm going to be around and I'll be able to nag them for longer. So they can,
that's
keep hearing it from me.
And also, as far as your mother goes, I think another thing that I think women have to know is that even if your doctor tells you like, oh, you don't need to get tested, if you feel like you do, you just tell your doctor.
To advocate.
Yes.
You have to advocate for yourself. My mother, I know she was kicking herself. She was so angry that the doctor said, your ovaries are shriveled up. She was so angry that she just took that and was like, okay.
Right.
Yeah.
That kills me. That makes me so sad.
Yeah.
Yeah. Because I guess she could have done what you did. She could have done
something. Mm-hmm.
Well, as we keep saying, knowledge is power.
It really is. And as traumatic as it was, I'm really glad I did it.
If you're now wondering if you should get genetic testing, the website for the American Cancer Society has a list of circumstances that could qualify for testing. I did Ambry's genetic test. I took the online questionnaire, which was really simple, and from that, I was identified as high risk. They sent me a kit in the mail, which came with a little vial and instructions, and I just had to spit into the vial. I actually recorded myself taking the test, but it did take me 10 minutes to fill the vial, so I decided not to include that in this podcast. I mean, no one needs to listen to me spitting for 10 minutes. So when that was done, I closed the vial, shook it up, put it back in the box, and stuck it in the mail. A couple weeks later, I got an email with my results. That was it. At the beginning of this episode, I asked, what if you had the ability to look into the future and see if you were at risk for cancer? Now let me ask you this. If it means spitting into a vial for 10 minutes to prolong your own life or the lives of your family members or your children, is it worth having a conversation with your doctor? Knowledge really is power. And like my friend Jennifer, you could be a previvor too. You may have noticed a recent trend in professional sports, excessive injuries. But it's not just happening on the professional level. Athletes across the sporting world are sustaining all kinds of injuries. And researchers found that athletes were 3 times as likely to sustain injuries following the COVID-19 lockdown. So what exactly is happening? On the next episode of Your Body, we're taking a look at sports injuries and how you can keep your body strong and resilient.
As traumatic
Thanks
as
for
it
listening.
was,
If you want to learn more about this healthcast or some of our guests, please visit www.yourbodyshow.com. And if you'd like more information about RadNet, check out www.radnet.com. Your Body is produced by Steve Kramer, Doug Smith, and me, Stephanie Landon. Technical and research assistance provided by Joseph Wilson. Executive produced by Paul Colacchio and Karen Morad, all on behalf of RadNet. Original theme music by Mark Lakier. We hope you've enjoyed our healthcast. Find us wherever you download podcasts.